Jenna. I am here today for something really special. So if you've been watching what we posted lately, you'll know that we did a 3-part interview with Rachel, who is another mom whose daughter had PRS. The interesting part is that Rachel and I both had the same plastic surgeon and ear, nose, and throat doctor. But her daughter ended up having a jaw distraction or mandible distraction, and Ava had the TLA or tongue lip adhesion. So we've been kind of talking and exploring in our conversation, well, why was the difference made? And we had to do a lot of speculating because, we're not the surgeon and we can't speak to why the surgeon made that call. And if you listen to the whole thing, you'll know that ultimately the surgeon kind of looked at us and let us pick and kind of follow our gut. And we were both really curious, well, why did Ava have tongue lip adhesion while Ellie had a jaw distraction? I did send an email to the plastic surgeon prior to filming the interview, but she didn't have time to get back to me at time of filming. However, not only did she get back to me, but she offered to talk on the phone and answer all of my questions, which is fantastic. So for privacy reasons, to protect Ava and my family, just so we don't have last names or location, I'm not going to say the doctor's name. It wasn't because the doctor said don't share my name. It's more to do with our trying to keep privacy a little bit for us. So I won't be saying her name or our location, but I will share what she told me because she said that I could, and I think it's really cool and interesting information. So I have notes on my phone. I tried to take really thorough notes, so hopefully I have everything. Now, I am not a doctor, so hopefully I am repeating and remembering and understanding really everything that she told me clearly. If you have any clarification questions, you can put them below, and I'll try to see if either I worded something funny when I filmed this or if I need to do any follow-up clarification, because I want this information to be as good as possible. But like I said, I'm not the doctor, so I am just kind of regurgitating the answers that she gave me. So the first thing I asked about was nasal trumpets, because I always had a question about that since they use it a lot in the UK, but they don't really use it in the States here, and at least not that I've heard much of. In the States, what I've heard more is jaw distraction, tongue lip adhesion, or a trach. And so I wasn't really sure, especially because the nasal trumpet is a non-surgical option, why that wasn't utilized more frequently. So our plastic surgeon said there's a couple reasons. She said that one, NICU nurses aren't always comfortable doing the change. She thinks that in Europe, because there's centralized healthcare, there's better home visits and they have better access to home visits, which is ultimately better for a nasal trumpet. So she says it's easier than putting a feeding tube in. And so sometimes in NICU, they will use it to wait for the baby to get large enough for a jaw distraction. And if you don't know what a nasal trumpet is, basically it's a piece of plastic that goes down the nose, through the back of the throat, and it holds that tongue down. And there are plastic pieces that come out the front, and then you can tape them to the baby's face. And it's a plastic piece that helps keep that tongue down and again clear the airway for a PRS baby. She says part of caring for a nasal trumpet is that you have to take it out and clean it once a day, because it can get really packed solid with boogies if you leave it in, basically, and boogers. And so sometimes people are nervous to take it out, which is understandable because they don't want to risk breathing complications. So because NICU nurses, or even sometimes the parents who are changing out the nasal trumpet, when you think of the baby having a difficult airway, if you take a plastic piece out that is preserving that airway, it's really nerve-wracking. And she says that that's why sometimes the NICU nurses aren't super comfortable taking it in and out like that. And I don't know if that's a problem where if we just had more training here, that it might start being used more often or not. But as of right now, with our current healthcare system and setup, like most of the time they haven't been using the nasal trumpet. And she said from her standpoint, a nasal trumpet is used more for management, to get a baby big enough to get to jaw growth. Because as you know, some PRS babies, their chins will naturally grow forward, and sometimes it's just a little bit more forward is going to solve the breathing complications and just to get them through that hump. She says it's used more in the UK because it is more standard practice there. That means, like we were talking about, they probably have more regular training on a nasal trumpet. And she also said that in the US, they do tend to lean more towards surgical procedure. So if a nasal trumpet were to go home, it's just not a standard practice. And a lot of US doctors aren't even trained in it. So I thought that was really, really fascinating. I keep finding out more ways that where you are located and the doctors you have access to can impact your medical path, which seems like a really obvious thing that, like, well, duh, of course, like if the person you're talking to only has one set of training, those are going to be your options. But you don't think about that, and especially if you don't know to expect a PRS diagnosis, your baby has come out, is not breathing. It's not like you really have time to do research to be like, hey, do you know this option? Or should I move my baby? Because sometimes that's just not a possibility. So it's just been really, really interesting. So nasal trumpet isn't always an option for the US. So the next thing I was asking, well, what's the difference as far as why would you choose a TLA versus a JD, or a tongue lip adhesion versus a jaw distraction? And so what she was saying is that in the United States, there is a lot of difference geographically in the training and then preference of TLA versus JD. A lot of it, and most of it depends on where your doctor is trained. So jaw distraction does require special training. Plastic surgery training usually goes, she said, into a pediatric or a craniofacial fellowship. So you have to choose one of the two paths anyway, and then it's going to be location dependent on how much exposure you get to TLA or JD, right, during your training, and who you're trained under, and if that doctor has a preference. So say you take the path where you do, where you're interested in craniofacial fellowship, right, and that training. Well, then you're still under the influence of who you're training under. Well, maybe their preference is to only do jaw distractions. And so that's the only surgeries that you're going to have access to. So say in the course of that fellowship, you only see one jaw distraction, or you see a bunch of tongue lip adhesions. That's going to influence what you feel comfortable doing as a surgeon as well, which is interesting. So our plastic surgeon says that she was trained in both, so she tends to not push one or the other unless there is a really known medical issue. I think that's probably why for both me and Rachel, she was kind of like on the fence and not pushing hard for one or the other. Again, to reiterate, the choice can be very surgeon specific on what they're familiar with, but you don't want your doctor doing a surgery that they are not familiar with either, especially with the risk for, like, say, jaw distraction. There's a lot of nerves in here. If you push your doctor to jaw distraction, but they're not familiar with it, they definitely can't if they don't have that specialty training too. But like if they're not familiar with it, then you run, I think, more risks. So always ask, how many of these have you done? What's your experience? What's your comfort level? Like those, I think, are okay questions to ask a surgeon in the lead up to a surgery like that. I did also want to ask her, because of the horror stories that I've kind of heard, just people telling me because of starting this vlog, what the variations of the tongue lip adhesion are. She said that there are some, where the button is, where the stitches are, and then how long to keep the baby incubated. She said it can be based on personal preference and anecdotal things that they've heard. So if they've heard about the TLA, that the babies only need to be incubated 2 days, that might influence the surgeon's plan. She says that she personally keeps the babies intubated because the pain medicine can affect respiratory issues, and the swelling from the surgery can affect the airway. So if you give the stitches time to heal, you don't run those risks. Plus, if there's a lot of pain, then the babies aren't pulling on the stitches and you don't have to worry as much about the stitches coming out. So then it's like, okay, well, as a parent, you are kind of at the mercy kind of who you're around, right? Which is kind of scary. So I'm like, well, the next question is, what can you do as a parent? And she said, ask the doctors why they do things a certain way, because it can be based on their experience. Now, this doesn't necessarily mean it's wrong, but I think it's really important for you as a parent to know what's going to happen moving forward. And she said, nowadays, doctors do tend to refer Piroband babies to a craniofacial team, and that wasn't always the case. So if you are around a lot of people that are not familiar with PRS, like, I would highly recommend seeing if there's a craniofacial team in the area. An interesting statistic that she told me is that 70% of PRS babies can be helped with just positioning. And that means kind of like what we're doing with Ava for the first 6 weeks, not to lay them on their back, but to kind of have them facing down so that the gravity will bring that tongue forward as the jaw is growing in. So I think you've heard me talk about the fussy baby hold, where you have, if this is the baby's head, them kind of facing down on your arm here with their belly to your arm, because then they're facing down, the tongue is bringing down, and that can help bring the tongue forward. Having them sleep on their side or prone, I think prone is the right term, kind of on their belly. Again, gravity pulling that tongue forward, and it's going to feel weird because everywhere you look it says, you know, there's SIDS risks if they don't sleep on their back. But with PRS babies, they have breathing risks, right? They'll block their airway if the tongue falls back. So, all right. The other thing she mentioned that was interesting was that in the US, she does think that there is a lower threshold for surgery, even though we've got that 70% thing, where a lot of times they don't feel comfortable sending the babies home because in order to help keep an airway clear with positioning, you have to be very, very observant, right? You have to be listening all the time for that breathing, making sure she's not obstructing or the baby's not obstructing. And it kind of makes sense to me if I were a surgeon that I would want to lean towards, well, can I fix the problem while the baby's here in my care versus sending the baby home and just trusting the positioning, right? But I think that's cultural too. I think it's cultural. I also think it's based on our current healthcare system and what's available here. Not to say that the doctors are pushing surgery for the money. I actually don't think that. I think it's because the way it works to get back in to see a surgeon, to schedule an appointment, to go through it, ER or urgent care, if there's a problem. Like, there's a lot of kind of setups of our system that would make it harder for the follow through, versus like in the UK, like we were talking about at the beginning of the video, how let me make sure I have to say the right thing. Centralized healthcare, they have like home visits and stuff, right? So that there's that constant checking in and like, hey, how are you and the baby doing? How are you putting the baby to sleep? How's the airway going? Like, those kinds of things we don't have here in the States. So it's very, very fascinating to me. So the other thing, you know, so I'm trying to reiterate this the best I can, but it was a really fascinating and interesting conversation. So the next thing I asked her was, when you're trying to decide what path to take in a PRS case, what are you looking for? Like, is there anything that I as a parent can kind of be aware of factors that you're considering? Some of these I kind of knew like from my gut, and some of these I think make a lot of sense. I just didn't think about them. So weight gain. So obviously with Ava, she struggled to put weight back on, and that was an indicator that she might be more likely to need a surgery. Can the baby get through a diaper change? Like, can they have brief moments on their back where their airway, while not ideal, you could still have enough time to change a diaper? The next one is to make sure that there's not significant obstruction when they are on their side. If the baby is still obstructing when they are on their side, positioning might not solve that problem. What's the parental availability to focus on the baby, and then what's best for the family? So when Ava was born, she was my only child, and I was staying at home, knew I was going to be a stay-at-home mom. That meant that I had basically 100% of the time to focus on listening for the breathing, being present, taking it moment for moment. But say I had 3 to 4 kids and I was a working parent and both parents were working, like at that point, it may be best for a family to choose the surgical path, because like the airway obstruction is such a scary thing, right? If the baby rolls onto their back, but you don't have someone around who's paying attention, and not because they're neglecting the kid or anything, but because say you're chasing after a toddler, just the baby has rolled on their back and all of a sudden starts obstructing, there's obviously a risk there. So again, parental availability and what's best for the family. The next thing they're considering is the size of the baby. Can they even fit in the, she called it the distractor, I'm assuming it's the machine to do the surgeries. Like sometimes you have to wait till the baby is big enough for those surgeries. And then also, how many more surgeries will the baby need? And all those things were really, really interesting to consider. I asked about sleep studies because I don't think Ava ever had one, and I know in the PRS group I'm a part of, a lot of people talk about the sleep study that their kid had. She said that sleep studies are really good for borderline cases, but that sometimes it can be hard to get accurate numbers, especially when the baby is in the NICU, which is really interesting. She did point out that there are some surgeons that will only do jaw distraction, so that is something again, that's really interesting, that some just won't choose to do a tongue lip adhesion. I asked, well, what was our ear, nose, and throat doctor looking for when he went down in the airway? Because for Ava, we had decided we were going to do the tongue lip adhesion, but we were told that until ear, nose, and throat looked down her airway, they weren't going to move forward. They had to check to make sure that tongue lip adhesion was going to solve the problem. She said they put a camera down the airway and they were looking for softening of the cartilage of the trachea. She said that there's some conditions that go along with Pierrot-Ban that have that softening, and then you can have obstruction happening from that. And then there's some of those issues that can't be fixed with a jaw distraction. And then the tongue lip adhesion wouldn't necessarily solve that problem as well. So when the camera's in there, they work with the ear, nose, and throat doctor to move the tongue to where the tongue lip adhesion would be, and then they see if that clears the airway. Now we were told at time of surgery, and then I know a lot of people have stressed, please make sure you mention this in your videos. The tongue lip adhesion does not work in all cases, and so I did ask the plastic surgeon, has she had instances where that doesn't work? Because obviously I really like my surgeon, that choice really worked for Ava, and so it seems like, well, why wouldn't that work for other people? She said that she has had ones that didn't solve the problem. They're usually related to syndromic issues. So there's some issues where, I was talking about, there's softening of that cartilage, and they thought it wasn't as bad, and they thought we could still do a tongue lip adhesion and it might solve the problem, and it ended up being too bad and not working. She said there was another case where they knew that it might not work, but the family still wanted to do the TLA in hopes that it would work. So kind of going in eyes wide open. She says that sometimes they will need to do a tracheotomy because the baby isn't a candidate for the jaw distraction. Again, it's usually related to something syndromic. So if the PRS is not connected to another syndrome, again, the TLA is going to have a better chance of working. She said that 85% of the tongue lip adhesions are successful, and the failures that happen are usually related to syndromic issues, a low birth weight, and prematurity. So if your baby's born early, then it might not work as well. And she says, and I didn't ask for details on this, but she does say that there's a scoring system that they use to kind of judge it and gauge if they should move forward with that option. At the end of the day, the biggest takeaway from this is, she said, the biggest thing is to communicate with your doctor. Ask a ton of questions. Ask about their experience. Ask if they have preferences. Why might they have a preference on this particular issue? If you are in a position and you're finding this video and your doctor has just talked about these two surgical options and you're like, I don't know what to do, ask questions. That will help guide you. The other thing is, and I'm hoping that you got to see the interview with Rachel if you are watching this one, because I'm going to post it as a part 4. But something interesting that me and Rachel kind of came to the understanding and agreement on is that even though our paths were different, it ultimately ended up being the best thing that we did for our kid. So whether you do a tongue lip adhesion or a jaw distraction, like, follow your gut, ask those questions of your doctor, and know and trust that, like, this time period of the PRS baby life, it's the first year is the hardest for most cases. But hang in there. I know it's scary. I know it's hard. But man, the first moment after the TLA for us, when Ava laid on her back and was calm, it was like everything was possible again. Like it was this feeling of relief after this really intense surgical process and stress of the birth and all of that. So hang in there. This bit is hard, but it will be okay. So anyway, I hope you found this interesting. I find it fascinating, and I'm so, so grateful to my plastic surgeon who was willing to answer questions. So if she sees this, thank you. This is amazing. So if you guys have any questions or comments, go ahead and put them below. I'm also going to link the videos for the jaw distraction versus tongue lip adhesion interview I did with Rachel. That's a 3-part series. I will also put down below more links to Ava's tongue lip adhesion surgeries and stuff, so you can find more information about that. Thank you for listening, and I will see you guys later. Bye. Say hi, Ellie. Here you go. Yay. Mabel's here too. Oh, Mabel!